Hello, everyone. Thank you, Chad, for the introduction. I will just give me a moment as I pull up my slides. Glad to have everyone here, and I'm looking forward to discussing and engaging further. I'd love to understand the makeup of the room today. And so, really, I'm here to speak less from sort of the technology side, but really representing the healthcare sector. Okay, so as I was saying, I'm really going to talk about the perspective of responsible adoption of AI from healthcare institutions' point of view. But before I do, next slide, please. A quick note about Access Health International, which I'm representing today. We're a nonprofit think tank, advisory group, and implementation partner dedicated to transforming health systems globally. And today's presentation brings insights from our recently launched report, which is Towards Responsible Healthcare in Asia Pacific, that was kindly supported by AWS. So some of the guiding questions for today's conversation and the report as a whole really was, what are some considerations in Asia Pacific's healthcare context when we look to AI solutions? What are some of the regulatory and governance mechanisms that are in place across countries in Asia Pacific? I will not be going into great depth in this, but if anyone would like to know a lot more, the report has very descriptive information, country-wise illustrations well within the appendix that clearly detail the various elements in great detail. And number three is really exploring the role of healthcare institutions in reducing risk to maximize the benefits of adoption. In terms of the ethical principles for the use of AI, both for health and in general, there's been a lot of conversation and discussion about the various principles, and largely they map on to um, the same items here, which is under whose ethical principles for the use of AI, largely talking about autonomy, human well being, safety, explainability, transparency, responsibility, and accountability, ensuring that there's equity and inclusiveness, and AI that's actually responsible and sustainable. But one thing that is important for us to note as we think about AI in healthcare's context across different countries globally is that there are different social and cultural norms, political systems, and health system models that can really influence the extent to what autonomy, for instance, or what responsibility and accountability would mean, and how much of inclusiveness and equity is in terms of definition within these countries and systems. And so that can actually create a certain difference in how they go about implementing and some of the challenges they will actually have to face in terms of adoption and acceptance. Another area that's really important to consider, and these are just at a very high level, but these are conversations that need to go in greater depth, that need to be unpacked at a contextual level, because even when we are thinking of adopting AI in the healthcare setting, and then beyond the healthcare setting, and here there's also the conversation that's co-currently happening where you have health models, health system models now moving out of healthcare institutions into the community. So, as health systems themselves are orienting and changing in nature, becoming a lot more community centered and person centered, it is making it all the more required that solutions are also accepted by people, as in patients. And so when we look at that, we also need to understand how ready countries are in terms of technology for several reasons. One is in terms of rolling out adoption, given healthcare systems already having being at various levels of sort of maturity, as well as the burden of both disease as well as challenges. We see levels of health system readiness and health system stress that we can actually kind of factor in terms of what is required resource wise in being able to safely mitigate some of the risks that may arise when considering adoption of AI for the health sector. And so this is one aspect that needs to be considered. So if we were to look at group one, the reason we've in our report, we've actually grouped countries according to their high to income status and economy. So we've got group one countries, which are high income countries, group two as middle income, and group three as low middle income countries. And the reason for this is really just because we've noticed a pattern in terms of financing, in terms of health systems burden, in terms of disease and demographic transitions that all play a role in terms of the needs and the stresses that need to be considered when we talk about adoption. We also have other readiness indicators, for example, e-participation index, which really is looking at how well a government uses, again, I might be preaching to the choir here, um, how well a government uses digital technologies to engage citizens in public decision making processes. And high e-participation can be crucial because high scores indicate the ability for better policy reflexivity. And here we're thinking long term in understanding the ground realities. For instance, when AI is deployed and used in healthcare settings, there is always going to be an instance of unexpected um, consequences arising, no matter how much you actually have sandboxes and rolling out in phases. When there is a full scale adoption, there will over time be unexpected consequences. Being able to have a platform, being able to have equitable voice and feedback, particularly in the patient context, is crucial to be able to have long term trust not being eroded when we talk about AI adoption, so that the premise of what AI can really do, because we're talking about being able to close the gap through AI solutions in healthcare by augmenting, by assisting in terms of closing the gap on workforce requirements and being able to reduce, I mean, change the amount of work or the type of work that is being done in terms of specialization. So when we look at all of those factors, trust is still an extremely important component. And being able to voice concern, being able to bring that voice into the feedback loop throughout the whole responsible health ecosystem is also crucial. And so while these are early days, it's also important for us to look at what's currently ongoing at a national level. And so, what we've done is we've broadly mapped what the regulatory and governance and policy mechanisms are in place. And what we see is that you've got broadly six buckets under which these initiatives are happening globally. You've got policy, you've got legislation and regulation, you've got guidance that forms practical guidance as well as technical guidance in terms of regulatory guidance as well. Then you've also got research centered around risk, and you've got assurance, various standards that and other measures that can be put in place, for example, sandbox and testing, as well as education and training for various levels, including users. And you have healthcare specific initiatives for the same. And I'm not going to, again, as I mentioned, I'm not going to delve too long into this, but what I'd really like, I think, to just take note of is that we've when we look at, and here we've grouped these countries as is, what you would see is there is a broad pattern that can be seen. Group one countries seem to be slightly ahead in terms, and when we started this research, group two and group three actually was still quite a bit in development, but over the course of the months that we were conducting our initial research, we saw that these were then, many of them were starting out as no's, and then they actually started becoming in progress. And so what we're seeing is a gradual development of many of these initiatives in group two and three countries. It's just a matter of when, as we've seen evolve over the last year. But what we do see an area that is still not available across most of the countries, except for group one, um, is in terms of for all of the countries, you've got availability of AI specific provisions in data privacy laws And in cybersecurity legislation is not something that we see even in Group 1 countries, but we are seeing Group 2 countries take a different approach. For example, you've got Malaysia and Thailand that actually are putting such provisions in place. For generative AI in healthcare guidelines, you will see that most countries don't have this in place. However, in terms of guidance, many of the Group 1 countries do have guidance in place, but Group 3 is still evolving. So Group 3, if you're seeing guidance, in terms of guidance, they are still lagging behind. And I wouldn't call it lagging. I think they're still in progress with policy and legislation measures in place, and it's likely to be a matter of time when they get to these measures. And so, what we also see similarly, as you can see here, is in the research area, we don't really see a lot of initiatives in Group 3 yet. And education and training, there seems to be a bit more progress across all of the countries. And in terms of assurance, again, you see that more of these measures have been put in place in Group 1 countries. And to a great extent in Group 2 countries, you see some of them in progress. But Group 3 countries are still yet to have development. Again, this is based on data that we've reviewed, measures that have initiatives that were there as of March 2023, 2025. And so this may have already begun to change in some of these countries since. But what we are really trying to think about and talk about is at the institutional level. And so a lot of the legislation and the policy, the assurance mechanisms that we talked about really are at the developer end of things, but the ecosystem is developer deployer as well as healthcare institutions and users within the healthcare institution. So as I mentioned, we've been talking about initiatives that largely to speak to the developers and deployers and are enforced or being crafted by regulators and policymakers. But beyond this is the institutional role in managing risks and making it safe for use within the healthcare system. And so we believe that a risk-based approach allows contextual action and is the best way forward in terms of thinking of the framework to approach safe and responsible use of AI in healthcare. And the reason for that is because it shifts the focus from rigid compliance, where you have laws and regulations that go that do not look at the nuanced risk that is there. And we'll get into a little bit of what that means in the next couple of slides. But instead of just having rigid compliance where you have a regulation that says, okay, this is either this, for example, or it's not, whereas traditional SAMD type of risk categorization was just high risk, low risk, or medium risk. But here we are really looking at risk within the context of use. So really use case scenario based risk mitigation measures. And this is not something that's new to healthcare institutions, because that is the framework that we do use even with our normal workflows. So this is probably something that is familiar for healthcare institutions as a whole. Just as a schema, as a conceptualization of what I've been talking about, if I were to look at mapping what that ecosystem looks like, you've got the developers, you've got the deployers, you've got the sandwich of initiatives that are managed at the national level or even at the state level, or at a territory level even. But then you've also got institutional users that have a risk evaluation and mitigation system. And you've got a monitoring and reporting system. So these are the two vital components that we see as playing a role within this overall ecosystem. And it needs to have a feedback loop, because you need institutions to specify their healthcare use case, evaluate that risk based on an evaluation framework, reduce those risks, and then implement solutions to monitor for risk. And then when there is an incident, that incident needs to be reported, and why and how it happened needs to inform the national policies, legislation, that whole pipeline. And so there has to be a reflexive feedback there that is constantly reviewing and understanding this. This ensures that any long term, when you have adoption, any unintended consequences can be brought in, and there's an agile way for the ecosystem to respond. And this is vital to actually maintain and build that trust. So when we are thinking at an institutional level at the healthcare, and we're just zooming up at an overall health systems level, different countries will have different health models, health system models. You might have a mixed model. You might have a public healthcare system, solely healthcare, a public led model. And because of these variabilities, there will be different domains that may come under healthcare institutions, where perhaps all the decision making measures to roll out certain solutions could be happening just at the Ministry of Health level. It could be happening at a state health sector level. You might have different components. For example, you might actually have clinical work, you might have a biomedical research component that actually interacts with healthcare, the healthcare sector or the clinical side. You might have clinical R&D that is also there. You could also have health surveillance and health promotion that is happening in the community. You'll have primary care centers, as well as health administration that will happen. And also, if you have universal health coverage systems in place, for instance, then you'll also have um, agencies that will be handling that in different countries. So there's a variety of domains where AI, in terms of health, can come into play, even down to, of course, hospital operations and health system optimization. So mapping these domains and then understanding the roles, and really bringing in a structure, a governance structure at the institution, is also something that we need to start thinking about and mapping. And I'd just like to take a moment to define hazard versus risk. And the reason for this is, a lot of the times there is a danger of us thinking of an outcome, and a severe outcome, and really thinking that that is equal to risk. But actually, an outcome is, the negative outcome is really the hazard that we're looking at. For instance, risk is not equal to the outcome. So you've got a hazard, a certain thing that can cause a negative impact. And then you've got risk, which is actually how likely a person would be impacted if said hazard was they were exposed to that. And not all hazards require the same level of intervention, and the intervention level is really risk based. And so this is the important thing that we need to think of, something that is, again, familiar in the healthcare setting, because in healthcare settings we have something as simple as surgical intervention, which can actually go wrong, but that doesn't mean that it's dangerous every single time it goes wrong, every single time you carry it out, because there have been enough risk evaluations that have been done throughout the critical points, and then the dangers of something going wrong, the likelihood has been reduced to the point where the risk is minimized. So if we were to bring that same thinking and work and risk mitigation framework to adopting health AI solutions in the healthcare setting, this would also work similarly. Let's take just a quick, it's a very simplified example, of course, but let's say pulse oximeters. We know that it's been found to be less accurate for people with darker skin tones, leading to delayed hospitalization, poorer outcomes. So this is an example of existing health technology bias that's not AI related. And if pulse oximeters were then paired with an automated decision support tool, this would be magnified because there's an existing bias, and there's no one to actually check through this. And if the process flow lacks any human intervention to address this, then that goes unseen. In other cases, there could be AI specific risks that may not be fully captured, unintended consequences. And the best example I can give for this, that is not an AI example, would be, for example, ivermectin-treated mosquito nets were supposed to be highly effective in reducing malaria. But in certain parts of Africa where they were actually implemented, it became a currency because it was highly valued, and people stopped using it and started trading it between them in certain communities. And this is an example of an unintended consequence. So there are many unintended consequences that we may be able to simulate or think through, but there will always be others that may only be known when they unfold. So we do need to account for capturing that. And our risk systems institutionally need to be designed in such a way that such instances are captured and monitored for, and then communicated and cascaded up to the higher authorities. And for that, you also need a culture of acceptance and openness to ensure that that does happen. So as we think about risk, here, I'm sure in the health sector, if anyone's here from the health sector or any of the allied care sector, this must be a very, very familiar matrix. So I'll be preaching to the choir, but I just want to pause to highlight to those who may not be familiar with this, that this is a very good picture to show how you can have a catastrophic consequence with very low likelihood, however. So if you look at the top right hand corner, you can see that it's very red and it's extreme. And that's if the likelihood is almost certain and the outcome is catastrophic, then you have extremely high risk. But if it's a catastrophic outcome that has very rare, unlikely to happen in terms of its likelihood or frequency, it becomes just high or it's moderate. Similarly, something that's negligible in terms of its impact, but if it's almost certain to occur, can also still be of moderate risk. So you've got two outcomes that are very different in terms of the consequence, having the same amount of likelihood, ending up having the same level of risk. And that's just what I want us to remember as we work through this, that it is the risk level, which is actually a function of severity as well as the frequency, that needs to be addressed. And that is why we need to be contextual in our approach. So as I had mentioned earlier, we look at domains. Different domains can actually lend themselves different levels of severity in terms of the hazard. So I would say, for example, certain clinical practices may always start out with higher severity of outcome because of the nature of the impact. And even within the clinical practice, different clinical practice settings may have different levels of outcome. So there again lies that contextual difference. You will also have healthcare administration that may not be, not all of its operations will have severity of outcome, but that does not necessarily mean all of healthcare administration is low severity. So this is just a point being made that within domains as well, you will have subdomains that will lend itself to higher or lower severity of outcomes. So when we're talking about the hazards that we want to assess for, we are looking at two types of broad hazards. One is use case specific variable hazards, which means that depending on the context, the kind of hazard that you'll be facing can change. You also have baseline hazards that will actually be product or service hazards that will not that will be common. Excuse me. So, for example, data privacy, data security. These are two items that will actually remain the same as long as you're dealing with data. You will also have user skill gaps. No matter which user it is, in any setting, you will have to address user skill gaps as a potential risk. And if you have interoperability risks, when you're maybe, for example, accessing patient data that maps from different data systems, then you've also got interoperability risks that need to be managed. And why this is really important, if I were to just spend a few seconds more on that, is that the roles addressing risk at an institutional level will deal differently. And we'll come to that later when I land on a slide with a potential organizational structure for risk at an institution level. but just to keep in mind how the different kinds of hazard categories can also sort of must be thought about in terms of the role of who is going to assess what kinds of risk and what kinds of hazard. Here, what we have is really you mapping out a hierarchy of risk controls. And for anyone in the health sector who's done their PPE versus engineering controls, you'll kind of know where I'm coming from. In the health sector, in the research sector, we also follow through with this. We start layering on. So the higher the risk, the higher the greater the number of risk control measures that you put in place to bring down the likelihood of something that's happening. If the risk is extremely high and can't be mitigated, then you eliminate that solution altogether. But that is not the ideal thing if you have ways to bring down that risk. And so, if again, this is just a suggested hierarchy of controls, and it's by no means exhaustive. We are just imagining. It's an imagination, if you will, of what it could look like for users to think about as they go through potential mix of risk controls that they can use at an user level when assessing for risks. So as you can see, if you see low risk is green and high risk is red. And so as if you have a low risk, you could actually just mitigate it at the lowest level using internal controls, such as some local institutional level training, guidance, and education. And then add on some operational and process controls as it kind of moves up that risk level. Adding on more assurance internally as well as externally. And then, of course, beyond that, you have the product level regulatory requirements, as well as you may even in future have other institutional level requirements that will come into play. And by this, I mean that, for example, if you were to think about chemical hazards and then the use of poisons, for instance, both the pharmaceutical industry as well as the institution in healthcare are both governed by um, having to hold a license to be able to actually either hold pharmacies would have to have that to actually be able to sell that. You've actually got to have internal controls where you log in usage, and you have the same thing at an institution in terms of using it as well. And so similarly, you could have internal and external regulations as well as process and operation controls to make sure that there's no misuse as well. And so this can span both legal, technical, and governance types of controls as well, depending on the suitability for the given hazard and the level of risk. So I'm just going to give an example of high level, again, an actual desktop exercise of risk assessment. Will look a lot more in depth and detailed, and will obviously have to involve the specific healthcare users and the specific workflow that it needs to, that a solution has to be put into place. And then they'd need to kind of run that through on a desktop first initially as a desktop exercise, and then phasing it and testing it out before they can roll it out. But just at a high level, you could see that hazards will broadly be in certain categories. And if we were to take bias, for example, disparities in predictions or decisions that lead to unfair treatment of certain patient groups as a hazard that happens. And then a non-AI example would be clinical guidelines that are developed from limited clinical trial data sets or unrepresentative population guidelines that are just adopted as is to a different context. An AI specific example would obviously be biased historical data that is being used to train a module, and then as a result, it magnifying that. Now, Responsible use would mean ensuring that diverse and representative data collection is used, and then the model itself is trained on representative data, which means it's more fit for purpose. And then this would obviously have certain either regulations or assurance mechanisms where you have certain standards in place where you would know at an institutional level if you want to use a certain solution that they are certified to have gone through this specific training, that the module is actually trained on diverse and representative data collection data that is fit for your specific country needs or your specific community's context. Then more internally, you would have providing continuous training for staff. So that was an external example, right? Internally at an institution level, you would have regularly auditing deployed systems for biased outputs. Now, this could actually be done by the deployer themselves as a service for continuous maintenance. And then you could actually have transparent processes for monitoring and adjusting algorithms post-deployment, again at the deployer level. And then at the user level, at the institution as the user, continuously training the staff to identify such moments of bias, especially for AI-driven decision-making processes. And here, this is just another example where you may have an over-reliance automation bias, where you have healthcare deployers potentially overlooking where the workflow is designed, judgment being overlooked or being made contrary to the obvious evidence because there's an over-reliance of the automation. In non-AI examples, you could have a clinician who's beginning to rely solely on automated analyzer results, dismissing clear physical symptoms, for example. And so the point here is that these problems are not new or not specific to AI. They have been there before as well, but AI is just changing the way in which these hazards may present themselves. And so an AI-driven prescription system could actually suggest that a dose that the pharmacist believes is incorrect, but the pharmacist feels that because it's AI decision making, it is more right. And so they defer to the AI, resulting in adverse drug effects. So promoting that balanced approach where AI or machine recommendations support and augment but don't replace clinical judgment is needed. Training healthcare providers to critically assess these system outputs, making sure that clinicians are able to actually judge separately from the AI, not build over reliance on it, is important. So these will be more process and training based controls that can be happen at the institutional level, but it can also happen external to the institution through societies, to clinical societies even in future. And then this is just what we talked about, I meant use case independent hazards. So data privacy, data security issues can actually be at an institution level. If you have these solutions in place that need to access patient data, you could always have the hazards of unauthorized access. Again, this is not an AI problem, that's not new. You could always have had unauthorized access of patient data. That has happened even now, pre-AI, in terms of healthcare workers themselves accessing even manual patient data without legitimate reason, leading to breaches of patient privacy. But now you could also have health AI systems requiring large data sets that are now able to access sensitive information for training. And then you also have data security breaches or attacks that have also happened historically pre-AI that can now happen and affect AI algorithms that use sensitive data as well. And so the danger here is if there is no control put in place where there's human oversight, for example, even if there is a breach and it's changing the way in which these decisions are being made, and if it's completely automated, that's where then you wouldn't know if this has happened. And so this part would really be about ensuring the security breach does not happen. And that won't be really in the realm or the risk assessment, risk role of the user right at the bottom. but it will be higher up within the healthcare institution in terms of the data security officer, for instance, at an institutional level who might need to actually put these measures in place. And so now I just wanted to stop for a moment to just put this in place, an idea of how this might all look at an institutional level within the healthcare systems. Most importantly, for any risk management to happen successfully, there needs to be an organizational culture towards responsible use of AI. And it should align with the guiding ethical principles that we talked about. But also, this needs to happen in a manner where users do not feel like um, they would be pinpointed to, because historically, even with accident management systems within the healthcare space, successful management systems are built on openness and trust. And so, really, this begins at the leadership level. So, the institutional leadership needs to set the agenda. And under them, having an AI safety and health team would really help in setting that organizational guidelines, conducting in-house technical AI safety training, laymanizing these concepts, for instance, to a variety of healthcare workforce audience as well as patients, because they will also be at the users in their own right for some of these solutions. And critically ensuring that AI procurement in itself is in line with national AI regulatory requirements, and that at an institutional level, any regulatory requirements that may in future be required, we haven't seen that happen as of yet. For instance, having to hold certain licenses, for instance, or any document regulations at a healthcare institution level to be able to actually have solutions rolled out. So we don't see that happening yet, but if that were to happen in future, then ensuring that these healthcare level licenses, for instance, are in line with what's required. And then if you were to look under that team, you would have data protection officers and cybersecurity personnel. These are two roles that are probably already in existence, managing health data already. But here we're just thinking of AI trained and AI risk trained personnel. And in countries where this may emerge as regulations, then for them to actually ensure that they comply with such regulations as well. And then under the AI safety lead, you would progressively have departmental AI safety leads or domain safety leads who will really look at complying with the organization guideline, but auditing and monitoring department level safety training, managing those internal audits, because there will be a variety of use cases and workflows. And so looking at domain-based sort of assessments and management of these compliance, and ensuring that the monitoring and reporting of any incidents also is managed at this level. And then under them, you would have unit AI safety officers who will really work at the lowest level in terms of the actual workflow within which an AI solution is being used, where they would need to conduct assessments per workflow for risk assessments, make those risk mitigation measures, be part of any piloting phase or any rollout that's required, making sure that there's safety training compliance of the unit, and there will always be changes in resources and the structure of certain units. For example, different workforce on shift, for example, and different doctors, for instance. And so making sure that all of them are up to date in terms of training and compliance of the AI process flow to ensure that this risk mitigation stays in place. And if we were to just take a look at what this is, again, very high level, but what would that stepwise process be at that unit level? Number one would be you would specify the healthcare use case, right? And then you would evaluate the risk based on the risk evaluation framework that you have. And then you would reduce that risk by identifying risk mitigation strategies. and then implement the risk mitigation strategies to ensure that you bring down the risk. Now, for example, if we were to have a AI solution, there may be a couple of AI solutions available in the market that automates tumor detection and staging and so on. And so let's say that a unit is actually at the position where they are planning to integrate an AI solution like this into their workflow. Then they would actually have to look through the documentation, what these modules were trained on, how fit for purpose is it in their population, or their use case in terms of their country, whether their population group kind of maps on to what this model was trained on, for instance. And then other sort of regulatory considerations of each of the products that are available for them to actually think of purchasing in terms of implementing. Then they would also have to think about their own workflow. Now, we've seen this from going from manual processes to automation pre-AI as well, when we brought of automation in terms of digital technology as well. Not existing workflows don't always map very well to new technology solutions. So there's always a requirement to look at whether it works to be directly plugged in, and whether there needs to be a changeover. The changeover in itself might require things like training a person on how to use this interface and this system in order to just reduce that risk in itself, for instance. So really sitting down and evaluating each step of the workflow to understand whether this step is going to introduce a certain element of risk, and how what is the outcome of something like this, and how frequently is it likely to happen, and what is the kind of hazard that we're dealing with, and how will this best be mitigated. A lot of this at this unit level will be process and operational control. They are internal controls, but they will have to be done with a mix of some of the external controls that we're talking about as well. For instance, finally, when you're really looking at which product to be used, you will go back to the institutional guidelines on which products that the institution is allowing us to procure, and what is fit for your specific clinical purpose, your unit purpose. For example, if you're talking about tumor detection, does this particular product work in your context? And then you will likely start with a phased controlled testing, where you have it side by side. And there are many ways to go about this, where you'll actually look at real world, sort of controlled real world implementation to see if there is any unusual, unexpected issues that arise. And then you would put in place further risk mitigation strategies. So it will evolve a couple of rounds before you actually then roll out. But once you roll that out, you'll have a risk mitigation framework for that specific use case that needs to be managed and maintained. Because several parts of that same workflow can change over time. You can have a person who actually changes jobs, and then you might have someone else who comes in who needs to be trained on this. One simple thing can actually reintroduce risk, for instance. So all of that has to be managed locally at that level to ensure that that overall risk isn't carried through. And so if we were to, again, this is conceptual, so we are keeping it high level, but the idea here is, if you look at figure 9 versus figure 10, figure 9 is an illustration of the preliminary risk assessment. So before you actually finalize your workflow, you're looking at introducing this solution, and then you walk through the various types of hazards that you might have to actually mitigate. And let's say you've got clinical inaccuracy, you've got bias or automation bias. We've only put all of these down just for illustration. It's not going to always be all of them, but these are some examples. And this can actually be a lot more detailed when people actually carry out this, because they will have to explain the hazard in their workflow context. And then you would give a rating of how severe the hazard is, 5 being very high and critical, So, hazard would be non-serious, serious, or critical. And then the likelihood will be either very low to very high range. And then it's a function, so you multiply the impact rating to the likelihood rating to get your risk score. Now, if you were, and this is for illustration purpose, let's just imagine that the clinical inaccuracy is very high, the likelihood is very high, and the impact of that hazard is really high. Then ideally, the risk score is very, very high. And so you would have to then think about what is it in this particular instance is causing this likelihood to be high. You cannot, if you look at your figure 9 versus figure 10, after you introduce a mitigation measure, you can see for item number 1 that the risk score does go down, and it goes down to an acceptable level, it goes down to low, but the impact rating doesn't change. The impact remains 5, remains severe. But you can see that the likelihood goes down to 1, the overall risk score goes down to 1, meaning on the off chance that something happens, yes, the severity is really high, but it is very, very unlikely for this to happen. Therefore, it is safe to proceed. And so this is the kind of workflow or approach that we think would make sense. And so if you were to look at it, even with medium level risk, you can see the same thing for bias that we've kind of worked out, bringing that risk down through mitigation strategies. And then ideally, so everyone needs to move from figure 9 to figure 10 as a process. And that process will be first a desktop exercise versus actually physically putting those in place, having a dry run versus having sort of side by side testing as well alongside your usual routine services versus a control service before rolling out fully, like phased implementation of sorts, and so on. But this figure 10 will still have to be managed by um, someone who has a role of ensuring that the mitigation strategies that have been put in place are continued to be managed at that workflow level. And so, with that, I'd like to just conclude that a robust, responsible ecosystem requires extensive involvement, capacity building, and awareness of the health sector. A lot of the conversation has really been um, currently been along the lines of the regulatory side and the wider ecosystem, but we really need to also start thinking about how, at an institutional level, these things would need to be put in place, because one of the main issues in terms of equity is that in countries, because this is happening across economies, you don't only have it in high income countries, you've got it in lower middle income countries. There is a potential that AI will be adopted in urban areas among the private sector, for instance. And this, while this is amazing in terms of being able to really see rapidly how what the potential is, it can also, in a ironic sense, push the universal sort of equitable healthcare agenda further away, because it's unlikely that these systems, these solutions will actually reach those who are further away, um, because of the requirement of the investment of resources required to mitigate the risk before it can be implemented. So we need to kind of start thinking about this, start planning for it, and start thinking long term, even at a policy level of being able to put these measures in place at the institution level. So with that, thank you, and would love to hear your thoughts.
Thank you for that very detailed presentation, Miss Iman. I know we've reached the top of the hour and it's late in your area, but I hope we can give a few minutes to our participants if there's anyone who'd like to ask a question or share their comments or insights. I think our Executive Director, Sir Jai, would like to speak.
Just a quick remark, Iman. It is a very interesting work. Very happy to have you with us for the webinar. And I know the time zone, amidst the time zone challenges, that you were able to speak, and then very, very interesting and very detailed, especially in terms of the risk assessment. And then I also saw the slide on capacity building, which is also a very critical area for AHIN. Like one of the main focus areas are our core competence in digital health is capacity building. And especially we have a mandate for that in the region and then working together with the countries. So I really appreciate, but like if I don't have any question, just wanted to actually thank you for this. But if there are any questions from the audience, please do. I would welcome that, maybe at least one. Anyone? Do you have any particular questions?
The microphones are also enabled if you'd like to ask. Yes, Dr. Kevin?
Okay, I think Wise is faster. We need like a range of mobility among the uses of AI in healthcare, but according to the PowerPoint slide, I think we need more precaution, and so how to manage between the risks and the the freedom to use the AI in healthcare.
Thank you, Kevin, for your question. And really, that's actually one of the issues that we face is that we need to have a controlled space in which we can understand what those risks are and be able to actually have these exercises happening at the institution level to understand how to mitigate that and what are the kind of controls, even at a process level internally within the specific workflows that will work to mitigate this. So it's going to be an ongoing process. And that's sort of what we need a lot more research to also happen around this, I believe, with a lot more healthcare personnel involved. I hope that answers your question.
Are there any other questions? If there aren't, like maybe I will just post this to you, Iman. Like this is a very interesting work. Like, do you have any sequel? Like, do you have any further things in pipeline to take this further, or is there any plan? Like, and then of course, if there is anything that on the capacity building front, if there is a possibility that Access and AHIN could work together in this space, I think that will be fantastic. But going further, if there are any plans, that is also will be of interest to us. Let us know.
Thank you, Jay. First of all, I'd also like to thank Ahin for having me here. And I'm sorry that there were a bit of technical glitches, and I think, took a little bit longer, but really appreciative that I could come here and share some of our thinking along these lines. We don't have anything in the pipeline yet, but we would love to really be able to test some of these conceptual thoughts that we've actually had lined up and really see if we can work at the capacity building level with AHIN in future. This is something that we could build on our body of work together, perhaps. And so very open to collaborate and explore further.
Thank you, Iman.
Thank you, everyone.
Thank you.
Thank you. Good evening. Bye-bye.